in rounds. Thank you for participating today during a snowy March break Tuesday. I'd like to remind everybody about Grand Rounds Zoom etiquette. Please make sure that your microphones are on mute, and we invite you to write your questions in the chat for our question and answer period at the end of the talk. I'm now going to hand things over to Dr. Gilfix, who's going to introduce our distinguished speaker.
Hello, everybody. Some people are maybe away on March break. I know some stalwarts are still here. I can see the list. So we're very lucky here to have today Dr. David Jones from Harvard Medical School at Harvard University. I tell you, the genesis of this talk happened at one of our Division of Medical Biochemistry meetings. And we were talking about recent GFR measurements. Should they include race or not race? And when we kind of looked around the room as discussion, we found our particular division very diverse. We have people of African origin, we have people of North European origin, we have people of Chinese origin, we have Sephardim, we have Ashkenazim, we have a whole mixed bag. And after our discussion, we really couldn't decide some of these issues amongst ourselves. So for that reason, we invited Dr. Jones, who's actually had an article last year in the England Journal of Medicine discussing about race correction clinical algorithms. Dr. Jones is currently the Ackerman Professor of the Culture of Medicine at Harvard University, and his research has explored the causes and meanings of health inequalities. So we invited Dr. Jones. Maybe he can shed some light and help to provide some illumination for us who are perplexed. Perhaps he can provide a guide to the perplexed. So without further ado, I'll hand over the reins to Dr. Jones.
Excellent. Well, thank you so much for this invitation to speak. I can't tell you what the right decision to make will be, but I do hope I'll be able to provide good background as you consider that decision going forward. And as you'll see in a minute, I also do recognize the ways in which the situation on these issues is different between Canada and the United States. So again, thank you. I'm honored to have this chance to join you for this discussion of what we all can do as health professionals to confront the challenge of inequity in medicine. As I said, while the problems are distinctive on each side of the border, they are equally relevant in both Canada and the United States. The problem of racism is as old as both of our countries, in fact, even older. Ideas about health and disease have been central to race discourse for centuries. You can find claims about health disparities in the earliest encounters between Europeans and Indigenous Americans. 19th century medical theory was often explicitly racist, with physicians routinely asserting the inferiority of both Africans and Indigenous Americans. Efforts to deal with these problems have intensified over the past several years. In the United States, this was driven in part by the protests that followed the murder of George Floyd by Minneapolis police officers. In Canada, there has been outcry over the mistreatment of First Nations children at the residential schools. And there has been great concern about the ways that COVID has revealed profound inequities in the United States, in Canada, and every place else. These efforts have become controversial. Last spring, two of my colleagues published an essay calling for medicine to invest special effort and resources on behalf of people who have been historically denied the full benefits of healthcare. This actually triggered protests by neo-Nazi groups outside their hospital in Boston just last month. Historians have now produced a very large literature, these books shown here just scratch the surface, about the role of race in American medicine. Scientific racism was ubiquitous in 19th century medical theory. Even though medical theory and practice have been thoroughly transformed since that time, ideas about race and practices of racism have been shockingly enduring. You can find claims in any field of medicine throughout the 20th century about how race should affect disease risk or treatment decisions. Researchers in the 21st century have documented countless cases in which the healthcare system treats people differently because of their race or ethnicity. Now, there are many regrettable cases in which disparities in medical treatment reflect various levels of racism, structural, institutional, interpersonal, or internalized. It also turns out that our medical technologies have a race problem as well. One interesting example came to light during COVID. Pulse oximeters, a ubiquitous medical device, are less accurate in people who have darker skin. Device engineers have long known how to fix this. The problem, however, has not been considered severe enough to warrant a solution. And race also infiltrates these new tools of machine learning and medical artificial intelligence. In 2019, Obermeyer and colleagues described one widely used AI tool that predicted risk of death in sick patients. Since the tool considered healthcare spending, and since healthcare spending, at least in the US, reflects several forms of racism, the tool inadvertently built racism into its output. Whenever the data sets used to train AI algorithms are racialized, and essentially every health data set in the US is racialized, then the machine algorithms will be racialized as well. Now, those cases all involve what I would consider inadvertent racism. No one, I hope, tries to be racist to their patients. No one designed pulse oximeters to deliberately underperform in people with dark skin, although they did know that was happening. Today, I want to focus on a different set of cases, one in which doctors treat people of different races differently, deliberately, because they think it is the medically correct thing to do. Now, there are countless examples, countless places where this happens in medicine. Many diagnostic tests adjust the results according to race. Many treatment guidelines tailor their recommendations according to race in both US and Canada. There has even been one case in which a company marketed a drug in the United States by claiming that it was more effective in people who self-identified as Black than in other people. This, in fact, had never been convincingly demonstrated by the medicine's developers, but they won FDA approval nonetheless. Now, many scholars in the United States, people like Dorothy Roberts or Troy Duster, and many others have condemned the way in which this company manipulated race claims to sell its product. And since this time, the FDA hasn't done something similar. This remains the one and only drug given a race-specific indication in US history. Now, as I said, I have to acknowledge that some of this is unique to the United States. Here's one example. In 2007, a team of researchers in the US, led by William Grobman, developed a calculator to predict the risk of vaginal delivery after a prior cesarean section. That risk calculator, which was widely adopted in the United States with support of NIH, included adjustment for African-American race and also what they called Hispanic race. Now, interestingly, when Grobman teamed up with a team of collaborators in Canada to develop a similar calculator for use there, his team dropped race and ethnicity as a variable, and they explained, because of potential differences in ethnic and socioeconomic backgrounds between populations in the United States and Canada. Now, it's not clear to me what those differences might be. The diversity of places like Montreal or Toronto or Vancouver is comparable to that of US cities. I traded emails about this week with Jay Kaufman, an epidemiologist that some of you might know at McGill. And he pointed out that a higher percentage of people in Canada who have African ancestry were born in Africa than is the situation in the US. And that may be relevant for birth outcomes. But if you look closely at the two calculators here, they did not recalculate a new calculator for Canada based on Canadian data. They simply dropped the two race coefficients from the US calculator and left the other coefficients in place. And something there does not add up to me. And this VBAC calculator is not a unique case. Medical researchers in the United States are much more preoccupied with the use of race and ethnicity than those in Canada or really any place else. I recently finished an analysis of the reporting of race and socioeconomic data about patients in clinical trials, looking at data from every article published in 4 major journals in 2020. We found that over half of the articles published in these 4 journals included information about race or ethnicity. but there were significant differences based on author geography. For all articles that were written by authors entirely from the US, over 80% of those articles reported race and ethnicity. Well, if the authors were entirely from Canada, fewer than 40% of those articles did. Now, this difference likely reflects a range of factors, including specific federal policies in the United States, but I think it's reasonable to conclude that US doctors think race is a more relevant variable than do doctors in Canada or most other countries. Now, within the US, advocates of race-based medicine see it as an evidence-based way to contribute to efforts to solve health inequities. Critics see race-based medicine as the opposite, as neither scientific nor evidence-based, as just another form of bias that can accentuate health inequities. So over the past 5 years, activists, often medical students and residents in several cities, began to focus attention on these practices of race-based medicine. Much of this attention involved the one mentioned in the introduction, the formula that estimates kidney function, the estimated glomerular filtration rate. And this had become a topic of great controversy starting around 2017 or so. I was involved in an effort at Harvard Medical School, working with a number of medical students there who were pushing to drop race correction from eGFR. And that was partially successful. One Boston hospital decided to do so. The others at the time did not. I then worked with 2 of my former students to publish our own paper about race correction. Instead of focusing narrowly on specific tools like eGFR or the VBAC calculator, we described 13 tools drawn from across many medical specialties. In each of these cases, there was some evidence that justified each practice, but the evidence was often quite weak. And the implementation of these tools often leaves much to be desired. Many of them rely on a dichotomous variable. The patients are either Black or non-Black. And we feared that those tools, if used as directed, could exacerbate health disparities and not alleviate them. Here is one tool, the Stone score, that predicts the risk of a kidney stone in someone who presents to an emergency room with flank pain. The score assesses several factors, with a higher score indicating higher risk. If you look, you will notice that non-Black race is weighted as heavily as having blood in your urine. This systematically assigns white people to a higher risk category and directs medical attention, in this case, the decision whether or not to get a CT scan or other medical imaging, directs medical attention and resources towards these non-Black patients. Our article happened to get published right in the aftermath of George Floyd's murder and in the midst of the Black Lives Matter protests in the United States. It got some helpful press coverage that amplified the debates that had begun around eGFR. The debates even made it into Consumer Reports, which essentially took the position of warning patients as consumers of healthcare that they should be aware that their race might be used against them. Tensions around this issue in the United States in the summer of 2020 were further inflamed by allegations that the National Football League used race norming of neuropsychological tests to deny settlements to retired Black players who had suffered concussions as part of their play in the National Football League. They used a lower set of, essentially, well, it wasn't IQ testing, it was more complicated than that. But essentially they said the baseline scores for Black people are lower than white people. So if you measured 2 retired players who had the same score, the white person's score would be further from the higher white norm than the Black player's score would be. And so the white player would be more likely to get a settlement than the Black player. These efforts, nothing fires up Americans like the toxic mix of sports and race. These efforts energized activists and prompted congressional hearings and inquiries within the United States. Senator Elizabeth Warren from Massachusetts led a team of other lawmakers to launch an investigation of the use of race-based tools and algorithms. Their press release led with the NFL expose, but then pivoted to include the medical tools, including the work that my students and I had done. One of my colleagues from Harvard Medical School, Michelle Morse, who had long been involved in race justice work in Boston, at the time was in the midst of a Robert Wood Johnson Legislative Advocacy Fellowship embedded within the House Ways and Means Committee, a powerful committee in the US that helps to set the US budget. She pushed the race correction controversy onto their agenda, and the committee sent letters to many medical societies asking them to explain and justify their use of race in their clinical tools. The medical societies all responded to this request for information. You can't ignore the House Ways and Means Committee in the US. Their letters are fascinating. Most of the societies, including large ones like the American Medical Association and the American Heart Association, did what I consider the right thing. They acknowledged the problem of racism and health inequities, and they committed themselves to doing what they can to address the problem. Some of them even distanced themselves from these tools. The American College of Emergency Physicians, for instance, said that it had done nothing to do with creating or sanctioning the flank score. They had never recommended that any ER physician use it, and they did not think it was an appropriate thing to do. All of this attention has already had an impact. The NIH research network that had produced the race-based VBAC calculator quickly decided to drop race. Now, this was relatively easy for them to do because, as I said earlier, their version of the same calculator used in Canada had never used race. And so what they did is they recalculated coefficients with a different data set and ended up now with a new calculator used in the US that no longer involves race. After a slow and contentious process, a task force set up by a series of kidney associations has produced a new eGFR calculator that does not rely on race and actually seems to be more accurate. From my point of view, this is a win-win situation. It's race-free and it's better than the racialized calculator had been. However, it's not clear how quickly this will be implemented, as the implementation requires hospitals to redo their laboratory IT systems, and that has proven to be more complicated than many of the advocates would have anticipated. Last fall, the National Football League said that it would stop instructing its psychologists to use race norming, while also wrongly asserting that they had never done so. And the American Academy of Clinical Neuropsychologists called for the elimination of race as a variable in demographically based test interpretation. But there has been pushback. The American Thoracic Society has convened a working group to look into the use of race norming for pulmonary function tests. This is likely the oldest and best established of the various race adjustments in diagnostic testing. Some defenders of the use of race in pulmonary function tests argue that the differences between races and pulmonary function are an empirical fact and cannot be ignored. Others are skeptical about this. Members of the working group, which is still in process, have been very tight-lipped, but the sense I get is that they are struggling very hard to reach a consensus about what the right thing to do is with pulmonary function tests. The Endocrine Society, which developed a risk predictor for osteoporosis risk and hip fracture risk, another one of the race-based tools, has come out aggressively in defense of the use of race here. Other endocrinologists, however, have acknowledged some problems with how the tool uses race. And the Endocrine Society, last I heard, is considering establishing a task force to reassess this, but has not yet done so. And from my point of view, the response from the Society of Thoracic Surgeons is most interesting. The STS had established a registry of cardiac surgery procedures in the 1990s, and that's likely the most complete medical registry for any procedure that exists in the United States. Some of you might know the overall quality of health data in the US is terrible. There's no centralized repositories. The STS registry of cardiac surgery is quite good. And with this data, they have been doing very sophisticated analyses for several decades. Their data clearly show a race signal. Black people in the United States have higher operative mortality rates after coronary artery bypass grafting than white people by a factor of 19%. The STS researchers keep broadening their analysis to figure out what the cause of that mortality disparity might be, for instance, by testing possible confounders, such as socioeconomic status. Until they sort that out, they believe that it is appropriate to keep race in their calculators, and that the 19% increased risk is not clinically significant anyway. No one is going to change their decision about bypass surgery because their predicted risk is 1.2% instead of 1% or 6% versus 5%. Now, they may be correct about that, but from my perspective, if it's not clinically relevant, why include it? Its presence in the calculator potentially does damage by perpetuating the assumption that race is real and meaningful in medicine, a point I'll come back to in a few minutes. And several groups of authors, often led by researchers of color in the United States, have also pushed back, asserting that race and ethnicity really do matter. They are really grounded in genetic differences, and they must be considered. And meanwhile, they say that the narrow focus of the advocacy work that I've been involved with on race correction isn't really that relevant and will do little to relieve the longstanding health inequities that exist in the United States. So in part to respond to these critics, I want to make sure a few things are clear. First, as far as I know, no one involved in these debates has ever called for colorblind medicine. The question is, what is an appropriate way to use race and ethnicity? And similarly, no one has ever said that ending race correction will achieve the full goals of race justice in the United States, but it still might be a step in the right direction. And I also remain frustrated by an asymmetry that exists in medical thinking. Defenders of the use of race have demanded that race activists proceed with great caution before ending the practices of race correction. For instance, doing modeling studies to show what effects the changes might have. But no one ever proceeded with great caution when race correction was introduced to begin with. Now, I haven't done detailed research about each of the tools, but as best as I can tell, what happened in the past was that researchers detected a race signal in the data, offered a tool to address that, and immediately won consensus to implement the change, at least in medicine in the United States. And this was often done without a well thought out rationale for why the race correction should be used and without modeling how patients would be affected. And so in effect, they introduced tools without careful consideration and are now asking for very careful consideration before removing those tools. And that doesn't seem fair to me. In the US, the legal system does have some useful standards. Federal courts use a standard of strict scrutiny whenever government policies or practices take race into consideration. Medicine in the United States clearly has not relied on a standard of strict scrutiny. In fact, the usual approach, as far as I can tell, has been to use no scrutiny at all whenever race has been introduced into these tools. Now, this might happen because of centuries-old assumptions that race matters in medicine, and it might happen because doctors think that any use of race could be a progressive attempt to acknowledge and mitigate race differences, that this use of race somehow helps. So given all of this, where do things stand now? How should we move forward? This is the question that you had asked at the outset. The underlying question here is a huge one. Medicine must grapple with a fundamental and ancient question. Are humans basically the same or not? Medicine currently operates on the assumption that we are different and that doctors can improve outcomes by focusing on race differences. Critics, however, argue that race is a distraction and that its use does harm. As you can imagine, I side with the critics here, and I'll try to explain why. Now, I am not a nihilist. I understand many ways in which human differences are relevant. There are several distinct forms of genetic difference. The most dramatic by far is between people who have XX or XY chromosomes. There are also subtler genetic differences between people of different ancestry. And there are more or less random differences that crop up because of mutation. On average, people of the same genetic sex differ at 0.1% of their genetic loci. And some of these differences clearly do matter. There are some genetic variants that have powerful effects, such as the alleles that cause sickle cell disease or Huntington's disease. And there are many more common diseases whose course and severity are influenced by genes. And yes, there are some medically relevant differences between people of different ancestries. A recent report back in January relates to the debates about EGFR and found that people who have specific variants of APOL1 have higher risks of kidney complications from COVID, and that these variants are more common in people of West African ancestry. So sometimes ancestry does seem to matter. But we must tread with care. Sickle cell trait is much more common amongst people with West African ancestry than people who don't have it. But as McGill epidemiologist Jay Kaufman has shown, there is danger in applying these differences carelessly. Even though sickle cell trait is 25 times more prominent in African Americans than white Americans, most African Americans don't have it. It would be wrong to treat all African Americans differently because of a trait that exists in only a minority of them. And you could say the same thing about APOL1. Well, these differences exist, but how much do genetic and racial differences actually matter in routine clinical practice? This is an empirical question, and I've never seen anyone produce a good answer. For instance, what % of clinical encounters are significantly shaped by a genetic variant, especially one with a racial distribution? Or if you look at the most common causes of ER visits, chest pain, abdominal pain, back pain, headache, cough, shortness of breath, genetic factors might contribute, but usually they are not the decisive thing that is considered. Or if you look at leading causes of death, heart disease, cancer, COVID, accidents, COPD, genetic factors might again be relevant, but they are not decisive. I suspect, but cannot prove, that doctors and pharmacists would not do that much harm if their baseline assumption in most cases were one of humans' sameness. We are all part of the same species. Our physiology is quite similar. We have similar disease, similar responses to medical interventions. Now, I can imagine occasional race-based tools that might help. Suppose researchers develop a tool that has a robust empirical justification for race adjustment. Suppose that tool could alleviate health inequities. Would that be a case of an appropriate race-conscious medicine? Such tools certainly exist. Last fall, Annals of Internal Medicine published an analysis that shows that starting mammography screening 10 years earlier in Black women in the United States could reduce disparities in breast cancer mortality. And that certainly sounds like a good thing. So should such tools be used? Again, I would urge caution. When doctors do take race and ethnicity into consideration, as they do routinely in the United States, they risk causing many forms of harm. And I will describe 3 of them here: miscategorization, reification, and distraction. The first is miscategorization. Many of the tools that we included in our analysis of race correction divide the world into 2 groups, Black and non-Black. Some of the tools use the US Census categories of 5 races and 2 ethnicities. Now, no one in science thinks that these are robust categories in any kind of biological or genetic sense. Consider the case of Barack Obama. If he had his kidney function tested, most hospitals in the United States would have adjusted the results because he would be considered Black. But this makes 2 distinct errors. First, as is well known, he's only half Black. His mom was a white woman from Kansas of Irish ancestry. And second, the genetic alleles that were invoked to justify race correction for EGFR, APOL1, are most common in people of West African ancestry. Barack Obama has no West African ancestry. His father, as Trump told us so often, was from Kenya. Or another article just published last month in the New England Journal of Medicine stressed the importance of taking Hispanic health disparities seriously. That's certainly an important thing to do, but the category of Hispanic in the United States is a very confusing category. Someone who identifies as Hispanic might have ancestry that's 100% Indigenous American, 100% African, 100% European, or any mix thereof. And cultural practices and socioeconomic circumstances also vary enormously across this group. You could have 2 people who are Hispanic who really have nothing in common that's significant. Now, health professionals in the United States increasingly will say that race is a social construct, but now defend the continued use of race on new grounds. They argue that race isn't a proxy for ancestry, but race is actually a proxy for experiences of racism. Race labels capture something meaningful about lived experience, about the ways in which exposure to racism is internalized and embodied, altering physiology. That is absolutely a relevant concern, but it's problematic as well. Can you really infer experiences of racism simply from someone's complexion or self-identity? Now imagine 3 students that I might meet this semester in Boston. I can imagine you could do the same exercise in Montreal. One might self-identify as African-American, descended from enslaved Africans born and raised in Baltimore. Another might have been raised in an aristocratic family in Ghana. A third might be a second-generation Ethiopian immigrant born and raised in Boston. Do these 3 people have anything meaningful or anything meaningful in common in terms of their lived and internalized experiences of racism? Not necessarily. And they don't necessarily share much ancestry either. So why should our healthcare system in the United States treat all 3 of them as one type, Black, distinct from all other humans? The same argument can be made about Hispanics, Asians, or any of the other familiar ethnic groups. It simply makes no sense. I've increasingly come to believe that the use of any of the common race and ethnic categories introduces a structural error in the medical research. Since the categories and their implementation are flawed, I don't see how anything good can come from their use. But I am sympathetic to health researchers who often have to utilize data that is coded in these ways. I'll say more about this in a minute. The second harm that follows from our continued use of these simplistic race categories is reification. Believing that something is real when it's really not a distinct thing. For several centuries, scholars in the European intellectual tradition have seen race as a legitimate category, a natural kind, either because different races reflected distinct acts of divine creation, or because different races reflected divergent evolution of geographically distinct populations. In either case, the assumption is that race correlates with ancestry and that different ancestries are associated with distinct genetic variations. But there has always been a counter discourse. Johann Blumenbach, a German scholar who wrote about human diversity in the late 18th century, did define 5 races, and these are the 5 races that most people talk about even today, but he added an important caveat. One variety of mankind does so insensibly pass into the other that you cannot mark out the limits between them. And Blumenbach's intuition has held true. It has been repeatedly confirmed by physical anthropologists and now geneticists. The human population is cosmopolitan and well-mixed. Same situation for dogs and rats. Allele frequency varies along gradual and continuous geographic gradients on a global scale. And this was shown well by a recent analysis of 37,000 people who live in New York City. And you can see this continuous smear of genetic variation. You can see some people who have mostly East Asian ancestry, some people who have mostly European ancestry, some people who have mostly African ancestry, but there's a continuous variant of genetic there's a continuous gradient of genetic variation, and most of the people in the sample are somewhere between these rare poles. Yet somehow many people in medicine continue to believe that these old categories of race really do correlate meaningfully with continental ancestry. They continue to use phrases like white or black, black or non-black, or the US Census categories. The fact that doctors continue to use these categories perpetuates the pernicious idea that race is a biologically meaningful category. This reinforces the popular belief that race is real in some scientific sense. And this reification of race has many toxic and polarizing effects, at least in the United States. The third harm is distraction. Our ubiquitous reflexive focus on race diverts attention from other factors that are relevant, even possibly more relevant than genetics and race. Now, race is clearly an important problem. The fact that race disparities in life expectancy persist in the United States is a serious problem that must be solved. But class disparities are actually much larger, with a 12-year life expectancy gap between the richest and poorest Americans in the United States. I don't think I've ever seen a diagnostic test or a treatment protocol that explicitly considers class. Or consider pharmacogenomics, one of the first areas of genomic medicine that rose to prominence. The basic idea is sound. Humans have many drug metabolizing enzymes and receptors, and these vary between people. Many pharmacogenomic variants have a geographic distribution, which researchers have long interpreted along racial lines. Advocates of pharmacogenomics argue that we should prescribe differently to people of different color. As psychiatrist Sally Patel proclaimed in the New York Times, "I am a racially profiling doctor." But this is bad medicine. Many pharmacogenomic alleles have very small effect sizes. Most drugs are influenced by so many enzymes and receptors that the impact of any one variant is likely to be small. And the variants are typically found in just a subset of a particular group. Yes, one race or ethnic group might be at higher risk of being slow metabolizers of P452D6, but most members of that group have the wild type allele. It would be wrong to treat all members of a group differently because of a trait held by only a subset of them. But this happens in medicine time and time again. Moreover, there are many things other than pharmacogenomic variants that affect treatment outcomes. Cigarette smoking, for instance, upregulates drug metabolizing enzymes and decreases the efficacy of drugs. One of my classmates in psychiatry residency made a patient very sick by successfully getting her to quit smoking. When she quit smoking, her metabolizing enzymes downregulated, and her serum levels of clozapine surged into the toxic range, and the patient presented symptomatic with clozapine toxicity because of the success of her smoking cessation. And since the 1970s, researchers have documented many other ways in which life affects treatment outcomes. Diet, for instance, can have a huge impact, whether leafy greens, grapefruit, or charcoal meats. Now, when researchers test drugs, they almost always report outcomes by race and gender. Why not report them by cigarette use, or meat consumption, or geography? Any of those can cause statistically significant differences in outcome, and yet it's only race and then age and gender that get people's attention. And most dramatic of all, of course, is the impact of non-adherence. I don't know if Canadian patients are better than American patients in the United States, but half of patients in the United States are unable or unwilling to take prescriptions as instructed. Many studies have shown that poor, minority, or otherwise marginalized people have lower rates of adherence. Now, you can prescribe according to race or sequence your patient's genomes to practice so-called precision medicine, but you will have a far larger impact on your patient's outcomes by having a serious and respectful conversation about their ability and willingness to follow treatment recommendations. Now, I certainly recognize that it's easier to criticize practices than to implement or recommend solutions. So I feel obligated in a couple minutes before closing to make some specific recommendations. As I said earlier, I do not and have never called for colorblind medicine. As long as race and racism continue to structure access to wealth, health, and social resources, we need to study them. I support race-conscious medicine. The challenge is figuring out the best way for medicine to be race-conscious. I believe that we should consider to include race in the descriptive statistics of healthcare. Racial categories are partially informative of genetic ancestry and lived experiences, but we need to do a much better job with this. No good will come from dividing the world's population into Black and non-Black. I don't know what set of labels is the best set of labels to use, and this likely will be different in different parts of the world. And there are many researchers who are working on that problem. And while I support the use of better race categories in descriptive statistics, I am very wary of any use of race categories in diagnostic testing and predictive tools, in part because of the problem of applying a property of a group onto an individual patient. This will inevitably introduce errors of miscategorization, of assuming that properties described in a group apply to all members of that group. And this is a careless and potentially dangerous assumption. And meanwhile, any effort we invest in studying race, ancestry, or genetics should be matched, probably exceeded, by attention to socioeconomic status. Too often, research studies will say, we controlled for SES, but a race signal persisted. Well, how did the researchers control for socioeconomic status? Often by relying on a single crude static variable, for instance, the 2 or 3 tier measure of educational attainment. That is not adequate. whether or not you have a high school degree or not does not control for socioeconomic status. Social epidemiologists have documented many relevant exposures. Other health professionals should match the effort by these social epidemiologists and document high-resolution social measures for all of our patients in both research and practice. And we also need longitudinal data sets that allow the integration of socioeconomic exposures and experiences of racism over individual lifetimes. Now, yes, this will be difficult. I understand that. And it's easy for me to tell other people to do this hard work. But humans have accomplished many difficult things in the past. The United States sent 12 men to the moon and brought them all home safely. My colleagues at Harvard and MIT developed 2 of our country's COVID vaccines in under 1 year. We have an incredibly resourceful and well-resourced scientific establishment. We can solve this problem of descriptive statistics in healthcare if we really try. We need to commit to collecting more comprehensive data about patients, both in research and in clinical practice. And we need to develop clever ways to analyze this data. But we can do it. Our patients deserve better. And I look forward to hearing your thoughts and questions about all of this. Thank you.
Thank you, Dr. Jones, for a very wonderful, thought-provoking exposition of the material. I don't know if our group is any less confused or more confused, but definitely giving us words for thought. Just before I open the procedures for any questions for Dr. Jones, I just make just 2 little observations. One, I have actually a study in front of me saying a good 10% of people, when you ask them their ethnic identity, misidentify themselves, if you actually look at the genetics of the individual. So even ask people who they are, they often don't know who they are, or they just say they are. And secondly, to make it very specific, right here in the core molecular lab upstairs on the 5th floor of the E-wing, they're spending a lot of resources looking at 5-fluorouracil polymorphisms, which may or not be relevant, in fact, for the population you find in Montreal. I've had extensive discussions with Dr. Riviere there about this issue. And this is a Quebec mandated program. So it really affects us in health resources even here. So at that point in time, I'm just going to turn over the questions to whoever, and I'm sure Dr. Jones will be happy to respond. Thank you.
If I could just jump in, thanks, Dr. Jones. That was very, very thought-provoking and you know, clearly an important debate and something that we need to focus on. Given your expertise in the history of medicine, do you see progress being made over the last century, and can you future gaze into the next century and give us a sense whether we're going to get this right eventually?
The short answer is yes, there's been practice. If you turn back the clock 100 or 120 years, most medical schools in the United States, and I also think in Canada, either excluded racial minorities or had very strict quotas. It wasn't just an issue of race. Most of the elite US schools also had quotas for people who were Jewish or Catholic. So the medical profession is certainly much better than it was 100 years ago. I don't know the Canadian numbers, but the current population of physicians in the US is still far from reflecting the population diversity of the country as a whole. There are far fewer African-American or Hispanic physicians in the medical profession than there would be if barriers didn't exist. And at every stage that you go up through the hierarchy, it gets worse. So if you look at Harvard Medical School faculty, for instance, as you go from assistant professor to associate professor to full professor, the ranks become whiter and more male with each step of the way. And so there are definitely problems with the composition of the profession. Better, but there's still more work that needs to be done. In terms of this thinking about race and the use of race in medicine, and sometimes you could say, no, I think we're in a better position now than we were 2 years ago. Many changes have been made. Much more reflection is going on. People are asking hard questions and doing better studies to try to figure out what work is being done. Like if you look at the debates about pulmonary function testing, it's a really difficult scientific question. I think in most places in the United States, if you pulled 10 random African-American 20-year-olds off the street and 10 random white Americans off the street, the white Americans are going to have larger lung volumes than the Black Americans do. The question is, why is that? Is it about body proportions? There's lots of studies of leg length versus torso length. Is it about genetics? Is it about environmental exposures between birth or even in utero and age 20 that determines this? Hundreds of years ago, and going back to the writing of Thomas Jefferson, white thinkers have simply asserted that the pulmonary apparatus of Black people or of Africans is defective compared to that of Europeans. No one thinks that, but there's still a lot of diversity of thought about what might be going on. But at least now people are doing serious work to try to get to the bottom of that. If you go back to 2000, when the first drafts of the Human Genome Project were released with big fanfare by Bill Clinton and Tony Blair, the assumption was, and you'll see this a lot in medical writing by people like Francis Collins and Harold Varmus, and there must be equivalents in Canada, saying that the development of genetic technology was going to introduce a race-free future in medicine. And soon we would just simply sequence everyone and wouldn't need to use these race categories. That hasn't happened yet for a variety of different reasons. And genomic science continues to be seriously racialized in the US. Do I think that will be better by 2030? I hope so. Lots of people are certainly working on it. I've been involved with one team based here in Boston that's been looking carefully at this question of ancestry. People have, over time, like race became a questionable category. So people turned to ethnicity, and then people realized that ethnicity doesn't really mean anything specifically. So now there's a lot of interest in ancestry. And so some very clever thinkers have said, well, what actually is ancestry? What do we mean when we use that term? And it turns out it's really complicated. Our ancestry depends on what time horizon you're looking at. So if you asked me, where did people who have contributed genetic material to me, where did they live in 1900 versus 1000 versus 5000 BC versus 10,000 BC? You'll get a different answer depending on what time horizon you look at. And so if anyone is going to make a claim about the relevance of ancestry to medical practice, they really need to specify ancestry at what time horizon. And that becomes an incredibly difficult scientific question. If your time horizon is 100,000 years ago, we're all East African, more or less. And people have a very hard time wrapping their head around that question. Or a related issue that comes up, when people think about, well, surely it's important to include diverse people in medical research. There was controversy in the United States because the trial of the Moderna vaccine was delayed by a couple of weeks because the FDA told Moderna that they hadn't recruited a diverse enough population of research subjects in that trial. And as a result of that delay, Pfizer's vaccine was approved and came to market first, and Pfizer's profits have been gargantuanly higher than Moderna's. No one should feel sorry for Moderna, but that FDA intervention based on race diversity of its research study cost Moderna first prize. In human medical history, going back to Jenner, there has never been a case of race-specific efficacy of a vaccine. All the vaccines we've developed seem to work perfectly well in people, whatever their background. It's not clear why FDA thought this was such an important issue that they should delay research on a promising vaccine in the midst of an epidemic. And so, Moderna dutifully recruited a more diverse population. If you really cared about research diversity, you shouldn't recruit some white people, some Asian people, and some African people. You should just go to Africa and recruit people from East, West, and South Africa. That's where most human diversity resides. But if you mention that to US pharmaceutical companies, they will say, look, we simply politically, we can't do all of our research in Africa. That would look terrible. And so you quickly realize that much more of this is about politics than anything else.
I was just looking at our chat line, and I noticed you had a like from Dr. Des Gupta. Dr. Pickering asked about comment on guidelines for treatment of hypertension by race. You also have a like from Dr. Magdi and Dr. Blank, and Dr. Rosenblatt says as costs decrease for whole genome sequencing, there's less need to look for shortcuts and looking at subpopulation. It would be necessary to have databases cover the entire human population. So again, Dr. Pickering, since she was first, asked about treatment of hypertension by race.
Yeah, that's a hard one. And I'm sorry that Jay Kaufman couldn't come, because most of what I know about that issue comes from work that Jay has been publishing over decades. My understanding of the US data, as filtered by people like Jay and others whom I respect, is there really isn't good evidence for race-specific guidelines about hypertension. If anyone wants a reference, I can send you a great chapter that Jay has written about this, or you could just ask him directly since he's there. As far as I can tell, the studies have shown that for first-line treatments of hypertension, everyone should be started on diuretics, probably thiazides. A lot of the discrepancy comes up in the topic of around ACE inhibitors. And there are reports that ACE inhibitors work better in white people than Black people. Series of issues there. When this all came up, and this was early 2000s, the initial recommendations came out and said, more or less, we should use the fancy new drugs, ACE inhibitors, for white people, and use the cheap generic drugs, thiazides, for Black people. And maybe there was scientific evidence base for that, but that looks pretty rotten. In most areas of society, if you said we're going to give the crappy old stuff to Black people and the fancy new stuff to white people, you'd get flack for that. But somehow that was successfully embedded in the treatment guidelines. And the people who have done careful evidence-based reviews are skeptical about whether that's actually justified or not. And then it gets to the other problem I alluded to. What is a Black person versus a white person? How do you know? Which guidelines should you use for someone like Barack Obama? That New York plot that I showed that most people do not have some kind of pure continental ancestry. Almost all humans have highly mixed ancestry. And so it's been very hard to know how to apply population level data to individual people. There was a great article, this is probably from 20 years ago, by Ashwin Segal, who was a nephrologist who trained at Boston. I think he works in Michigan now, where he did a meta-analysis of the various trials that had been done of antihypertensives, and said that yes, at a population trial, if you have huge sample sizes, you can see differences. So beta blockers might reduce systolic blood pressure by a point or two more in white people than Black people, and that was statistically significant. Whether or not it's clinically meaningful is not clear. But if you look at the percent of patients of Blacks and whites who responded essentially the same way to hypertension, it was 80 to 90%. There were bell curves, but the bell curves were almost entirely overlapping. And so what that meant is that if you had a Black patient and a white patient in your exam room, 80% of the time, you should treat them as if they have equivalent physiology. And that's just not what the treatment guidelines do. And so I think that's going to be a controversial area going forward. As for the cost of whole genome sequencing, yes, those are following quickly. What we need to figure out how to interpret all of that data. Genetic science that exists today is completely unrecognizable compared to what I was taught in medical school. And I'm sure many physicians in practice have had that experience. So it's very hard to keep up. And we need to have much better data sets. One of the concerns, you'd mentioned the 5-4 uracil. There's a similar concern about polygenic risk scores. Most of them have been developed of people of European ancestry. It's not clear, or it's clear that they don't work as well in people with other kinds of ancestry. So what should we do? Should we try to develop population-specific polygenic risk scores for every use, which will require us to define what is a meaningful population, which is hard to do? Or do we do research on more diverse populations than we have so far and simply create a polygenic risk score for humans where that score reflects the full range of human diversity? I don't know which of those things is more likely to happen, but we need more work to figure that out. And as I said, I think all this effort we invest in sorting out the genetics should really be matched, if not exceeded, by efforts to figure out the impact of social and environmental exposures. the funding gap currently is entirely in the opposite direction. NIH funds much more spending on genetic studies than on social and environmental studies. And I don't think that's warranted, and it has to change.
I see Dr. Rosenblatt had an additional question. Yesterday was Rare Disease Day, and patients with rare disease are also underserved too. So that was his comment on the issue too, which it actually is.
And as I said, I'm not a nihilist about differences between people. There are many rare diseases that have powerful genetic origins. And so we do need to somehow craft a system that figures out when, where, and why diversity is relevant. So there are cases in which having a particular allele is highly relevant for your medical prospects. And you have to acknowledge that. But much of the time, I think we could get away with just saying, look, we're human, and that is sufficient to guide our treatment decisions. And I think we'll take a lot of work to figure out which categories. It'll take a lot of work to figure out when we do need to look for and acknowledge difference and when we can get away by assuming that we're all human.
I was just wondering if anybody else has some questions, either coming live or on the chat line at time, because we still have a 2 or 3 minutes left in our appointed time. I should point out that sometimes part of the argument comes down to sort of, are we lumpers or splitters? Of course, are we splitters justified, to put it sort of in a very colloquial term? So sometimes maybe our own particular biases and how we approach things. Do we tend to be a lumper or a splitter? And I must say, when we'll be meeting next in our Division of Medical Biochemistry meeting, I'll be interested in the feedback from our group. Are we going to be lumpers or splitters? Because we actually have to do something specific. Do we modify our GFR measurements? Do we have any laboratory-based other numbers which sort of specify race? And as you pointed out, our population in Montreal, if you're just looking at blacks, we have people from the West Indian origin, but we have a lot of people from Haitian origin, and we have people from direct African origin. So I'm not even quite sure what even that means. It's sort of like using skin color as sort of a shorthand to suggest there's sort of some sort of genetic biochemical differences, but I'm not even quite sure what that even means anymore.
Yeah, and the questions of politics and identity are really complicated and really important. I mean, as you can tell, I'm in the lumper category, given that choice between lumping and splitting. But I've gotten feedback from some prominent minority health activists in the US that my willingness to be a lumper is a reflection of my privilege as a white person. Whereas for these people coming from underrepresented communities who feel disenfranchised and taken advantage of, for them, splitting to say you need to acknowledge our difference is an important part of their identity. And I don't know how to navigate that tension.
I think we're almost up at our time, if Dr. Rogers agrees. So I'm going to thank Dr. Jones for an amazing and sort of thought-provoking discussion. Hopefully it'll give us a little thought and we just don't sort of leap into making certain assumptions. We should always be looking at always to where we're coming from in our decisions, etc. So,
excellent. If anyone has follow-up questions, I'd be happy to entertain them by email. So thank you so much for your attention.
Thank you very much. That was brilliant.
Okay, thank you. So I guess I'll thank Dr. Jones again, and I'll say, bring our session to a close.